to everyone. So today we have two distinguished guests to present.
I think you have to count from 10 to 0.
To count to 0?
10 to 0, and then they start the screen with the stream.
Okay. No, I think we start. Okay, so good morning to everyone. Today we are receiving two distinguished guests to present in our meeting at the Department of Psychiatry at the University of São Paulo. So I would like to introduce Marco Solmi. Marco Solmi is talking from Italy. He's a psychiatrist and a neuroscientist. He is an assistant professor of psychiatry at the University of Padova in Italy. And he is one of world expert by several metrics worldwide. Today he has more than 180 publications, an age index of 42. And we also have Professor Christoph Correll. Professor Christopher Correll has 2 appointments as professor in psychiatry, both at the Free University of Berlin and as a professor in New York. He has more than 500 publications and an age index of 62. He has several grants worldwide. Also one of the top cited scientists in psychiatry. And so we are very pleased to receive the 2 of them to present data on mental health in the context of the COVID-19 pandemic. So Marco, I would first invite you to start your presentation, and we are very glad that you are here with us today.
So good morning to everybody, and thank you for inviting me to share our work on the COH-FIT project. I guess you can see now my presentation. So today I'm going to talk to you quickly about what the COH-FIT project aims to achieve and what is the theoretical background and what we expect might be the impact of this project. So COH-FIT stands for Collaborative Outcome Study on Health and Functioning During Infection Times. This is my disclosure. I have no disclosure. And of course, we are talking about the pandemic. This is the one of the most referenced platforms that you all know. It has been set up by the Johns Hopkins group. And we can see that to date, almost 9.5 million of people got infected by the COVID-19. And almost 500,000 died because of the infection. Of course, these figures are impressive, and this is clearly an unprecedented event at the global scale. However, these figures are also probably underestimating the impact of the pandemic, because the cases are just people that got tested, and the deaths are just people that, again, got tested and died. So probably the figures are even higher. However, I'm not going to talk to you about the impact of the pandemic itself, but rather on the indirect impact of the pandemic. So this is what we try to measure with the COH-FIT study. And the COH-FIT study started actually with during an informal call that I was having with Professor Correll, discussing several projects, and we were also sharing how stressful the situation was and is still for all of us, both as components of the general population as persons, but also as professionals. And also we shared how much our patients were suffering for this pandemic, and mainly, or at least partially, because of the poor access to care that they were encountering during the pandemic. So the whole thing started around April 1st, and since that time we managed to include just in a couple of weeks, 2 or 3 weeks, I remember around 150 researchers represented over 35 countries, more than 50 institutions, and we already planned since the very beginning to translate the survey in several languages, as many as 25. But then things actually got even bigger than what we were actually expecting. And I'm going to show you a little bit about this. So this is the hub. This is the beating heart of the project, is the website. What you have to do, first of all, when you go to the website, is click here, take the survey. And not in English, though. You will have the opportunity to take the survey, of course, in Portuguese, in Brazilian Portuguese. So again, this is the website. First thing, take the survey. But if you want to play around a little bit, you can also have the big picture of the size of the project by taking a look at how many languages you can take the survey on. Here we have around 29 languages. And again, you can see here there is a dedicated page for the collaborators. Here you can see that the countries, the colored countries, have some collaborators. So the colored countries are those where we are actively promoting the COH-FIT project. In Brazil, we have 5 collaborators, and Professor Brunone is leading the project in Brazil with other friends and colleagues who are all eminent researchers in the field of mental health. But of course, in this page, you can also see all the other collaborators. And actually, we are around 250 collaborators from around the world. We are proud to say that we have several very important organizations and scientific associations that are supporting the COH-FIT project. We have, for instance, the World Psychiatric Association. We have the European Psychiatric Association, World Association of Social Psychiatry, and other association, for instance, Association of Child and Adolescent Mental Health, so also adolescent and children's psychiatry. And one among all the organizations that has supported us the most actively has been the ECMP, and specifically the Prevention of Mental Disorder and Mental Health Promotion thematic working group, who actually also funded the project with some money to cover the costs. We also have several national associations that are endorsing and supporting the project. You can see here Africa, Asia. We have many from Europe, again Europe, and again Europe. So then we have South American associations as well. As I said, the funding, to date, the project is virtually unfunded, apart from financial support from the ECMP Prevention Promotion Working Group. The vast majority of the expenses are being covered by Professor Correll funds and local researchers, as I am doing in Italy, where they are trying to cover the costs for national representative samples. So again, this is the website, www.cohfit.com, COH-FIT, and we invite you to take the survey here and share it as much as possible. So what is how is the COH-FIT survey structure? It is, first of all, it is targeting the general population. So this is not a survey targeting people with mental disorders, at least not specifically. This is targeting the general population. It has no restriction in terms of age. I think in Brazil right now, minors are not allowed to answer. So you are only allowed to share this with adults, but we have set this up so that in Brazil, minors cannot take the survey. But in general, worldwide, adults, adolescents, and children can all take the survey. And we have two ways of collecting data about minors. The first way is an indirect way by just asking the parents how their kids are doing. And via the parental rating, we get some information on how they are doing. And the second way is to have adolescents and children directly taking the survey so that they can answer themselves how they are feeling and how they're doing. The survey is definitely on the long side, let me tell you. Is 30 to 40 minutes for adults and around 25 minutes for kids. We are aware of this, but so far, despite the length of the survey, we were also honestly a bit surprised by the retention of the high rates of completers out of the people actually taking the survey. So we have around 60 to 65% of people completing the survey after starting it, which is after consenting to it. So it means that it's an acceptable tool. It has an adaptive structure, which means that depending on what you answer, you're gonna get prompted with different questions. So for instance, if I ask you, do you have a job right now? And you answer no, I'm not gonna ask you what type of job you are doing right now. So it has an adaptive structure. So also the length of the survey can vary depending on the responses that people give. There is no country restriction so far. This is an online survey. Of course, we have some countries where we are actively promoting the survey with some researchers that we are collaborating with, but we didn't formally put any country restrictions. So wherever you live around the globe, you can answer the question. It is completely anonymous. This is a very important point. We're not collecting any personal identifier. And the survey has a cross-sectional structure, which means that, of course, if we don't collect identifier, we cannot follow up people. So these two things go together. And so this survey has a cross-sectional structure. However, we try to still measure the longitudinal course of the outcomes that we are assessing by setting up a multi-wave design, which means that we have 3 waves. Wave 1 is the one that is currently running, and this will last until the WHO will have declared the pandemic over. Then after 6 months, we're going to start wave 2. And then after 12 months, we're going to start wave 3. The data collection during wave 1 will be a continuous data collection. So again, we expect to be able to infer some longitudinal course of the outcomes with regards in particular to the pandemic course and the restrictions. We know that different degrees of restrictions might impact mental and physical health differently. So we expect to be able to measure this aspect as well. What will be the outcomes? The outcomes will be, of course, about mental health. We have to admit we have an angle on this project, and we are psychiatrists, so our training and our interest are on mainly on mental health. However, this survey is not exclusively on mental health. It is also actually on social functioning, well-being, and also physical health, and also on how health services are, how much they are accessible, and how much telemedicine has been implemented in the health services. So the set of outcomes is pretty wide. I told you that this is a survey on the general population, but it's, of course, we're gonna expect to have, for the non-representative samples, a biased sample. I mean, we are all medical doctors, so or psychologists or nurses, so we are all health workers. So we will, of course, collect many data from health workers. workers. And health workers are actually an at-risk population during the pandemic. This is meta-analysis that we have recently got accepted in the Journal of Affective Disorders on the physical health outcomes in health workers. You can see that health workers are very badly hit also at physical level by the coronavirus infections. You can see here we are considering also SARS and MERS pandemic, which were happened in the last years. You can see, for instance, that fever goes up to almost 80%, fatigue to almost 40%, and cough to almost 60%. But most importantly, let me show you something else. These are the outcomes at the mental health level. So take a look specifically at these results. So this is about burnout. So if people, if health workers are developing a burnout syndrome, then of course the issue is, first of all, for them, but also for the patients that they're going to take care of. So health workers must be protected in this perspective. And we are gonna, of course, collect some, descriptive variables to identify health workers in order to be able to focus on how they're doing during this pandemic. And let me also show you something else here. This is the PTSD proportion estimation. So I read some recent publications where they reported 90% rates of PTSD. This is apparently not true, at least at a meta-analytic level. So PTSD rates are far lower, around 10 to 15%. So again, we must be very careful in interpreting results that we read in the literature. But again, health workers, of course, are a population at risk of developing poor mental and physical health during the pandemic. But they might also have some coping strategies and personal or psychological resources that might also protect them. And we are going to measure that. One more crucial point is the focus on women. So during the pandemic, people are forced to live together, and sometimes they were not used to, or they were not willing to. They might have no money to live in different places, or there might be pathological relationship. At the end of the day, people spend a lot of time and a lot of hours each day living together in the same house, and this might, of course, trigger some domestic violence, which is a problem. It's a major problem for women. It's also a major problem, however, also for the kids. We are currently trying to map, not in the COVID project, in other projects, the risk factors for mental disorders. And I can tell you that early traumatic events are the only trust diagnostic risk factors for all mental disorders, or virtually all mental disorders. So again, if we should we find very high rates of domestic violence, this might also be a very relevant finding, because this might ultimately have long-term impact on mental health of those that are now kids and will be adults in the next year. And then, of course, we're going to focus also on the elderly. The elderly have a lot of comorbidities, they have chronic conditions, and so, of course, they are fragile by definition. And one more category that we're going to focus on are people who are suffering from mental disorders, but I will leave this topic to a finer grained discussion by Professor Correll in the next presentation. But this is the big picture of the COVID contribution to the knowledge and to the clinical actions and policy actions that might be taken to face the pandemic now or even future pandemics. So we envision to identify non-modifiable risk factors non-modifiable risk factors are basically risk factors. So by finding non-modifiable risk factors that are associated with outcomes, we are basically identifying populations at risk. We are also going to identify modifiable risk factors. And on this side, we are gonna identify actually opportunities to intervene, because if a factor is associated with a poor or a better outcome, then if we modulate this factor, since it's modifiable by definition, then we might also impact the ultimate outcome. And this is relevant for health promotion strategies, health also for prevention of conditions, mental or physical, and also for early intervention in these conditions. And the ultimate impact of the COH-FIT project, which we envision, is influencing public health policy and guidelines. Our primary outcomes will be, we have two core primary outcomes. We will have the well-being WHO-5 questionnaire. Well-being is, of course, we selected well-being because we think it's related to mental, physical health, but also to social functioning. So we selected this as a proxy of the overall impact of the pandemic. And then, of course, as I told you, we have an angle as psychiatrists. And so we will create a composite P psychopathology score, which will be computed across several psychopathology domains. And this will be also a co-primary outcome. And for all the outcomes, we are going to measure the change, because we will ask, how have you been doing, for instance, about well-being now in the last 2 weeks, and how were you doing the last 2 weeks before the pandemic started? So again, we're going to measure the longitudinal change retrospectively on all the outcomes. The other outcomes will be social functioning, quality of life, general mental health, and general physical health. If you want to have a closer look to the outcomes themselves, just to give you some examples. So age is a non-modifiable risk factor. Job type is non-modifiable risk factor, at least, of course, in the shorter term. Again, marital status, socioeconomic status, gender. However, modifiable risk factors are, for instance, coping strategies, exercise, resilience. This might be a very relevant one. And then, again, you can see the core primary outcomes, well-being and composite mental health score, and then the key secondary outcomes, general mental health, general physical health, functioning, quality of life. And of course, we will have some of the factors that will be modifiable risk factors that, of course, can become also outcomes because or mediators or moderators of the ultimate outcome. So we are going to test this in our statistical analysis plan. Let's go to the survey. So when you click on the website, you remember, click the survey button. You click there, you are gonna be directed here. So you start here and you are prompted with the consent. You give the consent to participate. Let's say that you are an adult and you want to take the survey. You're gonna be directed to the COH-FIT survey, the adult version. Then after you do this, you are asked whether you are a guardian of some minors, kids or adolescents. And if you are asked whether you want to rate them. So this is the indirect source of information about minors that I was talking to you about. After you complete this parental rating, then you're going to be asked with the validation questions. Why the validation questions? Because I didn't tell you that to measure, for instance, depression, we will not ask the full PHQ-9, in this case, questionnaire. We just extracted a couple of items that on a clinical judgment we thought were the most relevant ones. But then in the validation section, we are going to ask the full PHQ-9 questionnaire. And in this way, we expect to be able to test the validity of the items that we extracted from the PHQ-9, just by running probably just a correlation. Then let's say that you have some kids and you are the legal guardian of them, and you also want them to take the survey. So you can move to the second part of the survey. It's actually, you actually have to go back to the website and take the survey from the beginning again. And you consent as an adult, and then you are asked to whether you want to take the survey or your kids will take the survey. You select your kids are going to do that. And so you're asked to do the parental rating of them. But if you already did it, there's no problem. You can skip it, because you will be also asked to input a code that will be able to link you to the kids, but not at a personal, it's not an identifier at all. And then kids or adolescents will be able to assent the study, and then they will take the survey. The adolescent one will be virtually identical to the adult one, apart from a couple of questions that we removed. One is on sexual activity, for instance. We removed that for the adolescents. And then adolescents will be able to do the validation questions as well. But if you are a kid, which means 6 to 13 years old, you will have a fully adapted questionnaire. It will be shorter, and the language will be adapted for children. This is what you see when you start the survey. This is just to give you the visual impression of what participants will see. And this is also to show you that in general, you will find multiple choice answers, sliders, and yes, no answers, basically. Very few drop-down answers, because that is more time-consuming, and people get bored with that. Here on the right, you can see how we are going to assess the change in the outcomes. For instance, this is about resilience. So we first ask how much do you tend to bounce back quickly after hard times now, and then we ask you, what about the last 2 weeks of your regular life before the pandemic? So again, in this way, 0 to 100, we will be able to measure the change. How many people participated to the project so far? So far, we have over 60,000 answers. You can see this is the color, the darker the color is, the more participants responded to the survey for each given country. In Italy, we have over 8,000 participants. For instance, in Denmark, we have over 3,000. And this is the big picture. Again, over 60,000 people responded, over 125 countries with non-representative samples had some answers, so to the survey, across the 6 continents. And we also have already collected representative samples of 1,000 adults in Italy, Greece, and Hungary, 2,000 adults in Austria, and we are starting actually today to collect 1,000 adults of representative sample, again, in Brazil, US, Germany, Switzerland, Spain, UK, and Russia. We are also collecting 250 adolescents and 250 children, representative, again, of the general population in Italy. What about Brazil? So Brazil, I showed you before the numbers. And in terms of the pandemic, this is very bad. Professor Bruni was telling me before starting the meeting, the situation is very, very bad, and people are very concerned about it. And a lot of people are losing their life. So the pandemic is fully active in Brazil. Again, over 1 million infections and over 50,000 people died because of the pandemic. The survey has just started actually in Brazil. So the numbers, this is from this morning. It's only 280 people responded to the survey because it has just started. So this is an opportunity to all of us to discuss some strategies to promote the survey, and also to answer to any doubt you might have. And specifically, what are the actions that are needed to disseminate the COVID survey? This seems trivial, I mean, but it's not at all. It's way more subtle than what it would like. You will not get numbers if you just send the link to your friends. So this is what you have to do. So first of all, you have to take the survey, no doubt, again, and then you have to share the survey with the family members, friends, and colleagues. But then you also have to ask them and chase them as much as possible, of course, to share the survey across their contacts, their friends, their colleagues. Then you're gonna have to use your institutional channels, if you want, of your hospital, university department, to maximize the dissemination. You, of course, will need to interact with TV, media, give radio interviews, make some news on the newspapers. So this is also necessary to see the numbers rising. One more important component also of the dissemination is the social media usage. So you will have to use them, and you will have to use them intensively. Both Facebook, I have a Facebook, Twitter, Instagram. You will, it might be a good idea to try to contact influencers as well. And let me also tell you that Facebook has a nice advertising policy. You don't spend much money for that, and you can reach like thousands of people with the link of the survey. But again, you have to dedicate some time and energy and focus a little bit on this. One more thing that we did in Italy and also in other countries, we contacted professional or volunteer associations. For instance, in Italy, I remember I contacted the Red Cross, and since when I contacted them, and in last week, I can't measure any causal association, but I can guess there is such a causal association. The numbers skyrocketed in the week right after contacting the Red Cross. So again, this is a very relevant strategy and very effective one. Also, of course, you can interact with the mental, physical health specialist associations, nurse associations, psychologist associations, patients associations. You can, if you want, target university students via your local university channels. And then, of course, if you want to get some numbers on the fragile populations, you must specifically try to target them, because otherwise you're not going to collect answers from the elderlies. So I think this is all I wanted to share with you. This is just, the big picture of the project, and I will be happy to answer any questions if you have after Professor Correll's presentation.
Great, thanks very much, Marco. Now, how can I start presenting? Present now, okay, so I'm going now present and take over. So first of all, I would like to thank, maybe Marco, you can mute yourself. There's an echo. Okay. So we have a problem here, present now, a window. So let me see. How can I give permission? I have a problem. Marco, can you share your screen? And did you include the new slides? Somehow I can't present.
No, if you want to send me your presentation, I can share the screen.
Okay. I don't know why I can't. How can I give permission? Okay. I'll send it to you right now. We don't have that much time, by the way, because you already heard a lot about the survey, which is great. And I want to thank Marco, without whom all of this would not have been possible at all, who's worked tirelessly day and night to actually make it possible for us to put a survey together and then also try to get some grants and interact with all the collaborators, which has been wonderful. And having you on board in Brazil is also a very strong point. You may ask yourself why it took so long for Brazil to start. Well, this has really to do with the fact that in the countries where we do the advertisement, we are asking for ethics committee approval. And you may know in Brazil, this can be quite complex and complicated to achieve such an approval. So we now have it in Brazil. You achieved it. Marco, I just sent you the slides. And we're looking forward to seeing an increase in your numbers also. What I try to do is to just highlight, obviously, mental health is not necessarily at the center of our attention during the height of a pandemic. But the problem is that due to the physical ill health and the stress and strain of a pandemic, of the restrictions, but also frontline work, mental issues come out. I mean, there's now a pan-cultural pressure and stressor that occurs, and we know that underlying vulnerabilities, genetic problems that predispose people to mental illness will come out. So new mental illness will be produced, not only PTSD, because of the gene-environment interaction, and also we will have worsening of people who have had mental illness before and either now don't have access to care and have decrease in adherence, or that have a worsening just because of all of the stress. So we felt that it was important during the pandemic, rather than just watching and being passive, to collect information and use that information to identify vulnerable subgroups that need help now, but also those that may have enduring mental health issues or late onset mental health issues, so that we can target them, but also learning about risk and protective factors and coping and resiliency strategies, so that we could then devise further personalized preventive and intervention measures, so that people can use a menu option of things that have helped others who are in a similar situation, either during lockdown or in a certain age group or in a certain region, whether it's a city or rural areas. So in that sense, our information will be very important. And we are now collecting maybe for another month or so, and then we'll have the first cut, trying to use the information in the completed surveys so that we can then write papers, but also inform policy on a governmental level, but also ideally inform people who are in local decision-making positions. Great, thanks very much, Marco. So next slide. We think, so this is my disclosure information. So please, next slide. Yeah, so what you are now in the midst of is the first wave, immediate mortality. You need to shift your resources. The resources go right into the second wave, that there are mental and medical health inequalities where patients don't get the care anymore because everything goes now into treating people who have the acute infection. Then the third wave will be, the third impact will be that those with chronic illness don't get the ongoing care. But what will be the big and enduring and long-lasting one will be the mental health wave, that obviously starts with the first, second, and third wave, but becomes a fourth wave itself because of the stressor, the trauma, the underlying vulnerabilities, but also economic injuries, because people will lose jobs and really will fall below some of the earning areas where they can survive. Next slide. So this is from a Lancet psychiatry commission that Carmen Moreno is first author and Celso Arango is the last one, and I'm one of several co-authors. And this is a panel that I put together thinking we must learn from the stressors now. So I put on the left-hand side changes that may worsen mental health outcomes, but what can we learn from that in our actions to actually then improve the outcomes. So basically, if there's social distancing, we need to highlight self-care opportunities, but also family support. Don't call it social distancing, but rather physical distancing. Make sure that now that we think a mental health wave will evolve and everybody is under stress, mental health and mental illness becomes a focus that we can now talk about. So destigmatizing mental illness and increasing mental health literacy is important. Also, if there is a dislocation of the team, trying to have rapid response mechanisms and also mental health counseling, not only for the general population, but also for our teams. And also we need to mobilize volunteers and retirees. Next slide. Also, we need to shift, as I said, from physical ill health to including also mental illness, so that basically physical and mental health become one. There's no one without the other. We have seen a lot of decrease in outpatient appointments, but again, using that to propel and propose conversion to online formats is really important. And there are multiple other things that we may implement, including less stringent monitoring guidelines, like for clozapine, for example, where we think that if there hasn't been a low white count in the last year, and people have been on clozapine for a year, you can actually do 3 monthly prescribing and also 3 monthly dispensing of clozapine, because the risk of agranulocytosis is exactly the same as in the general population. Next slide. Yesterday, this is again from the commission, where we have 3 major issues that should be monitored and that you can also monitor now in Brazil. One is, what is the physical ill health of the general population? Next slide. And what's the response to the pandemic? The next one is, what's the mental health problems that occur? Next slide. And then what is the outcome related to mental health problems in the long run? What are the downstream effects? Again, we don't have time, because we won't have time for discussion to go into this detail, but this has now been accepted and will come out soon in Lancet Psychiatry. And yesterday, next slide, we published online a brief viewpoint on 4 principles for interventions and how people with schizophrenia should be treated if they're very agitated on units. So 4 general principles: protect patients and families with education, information, and support; protect staff; prevent worsening and relapse by ongoing care; and maximize your efficiencies. Obviously, you also need sleep and social connectedness, because you're in there for a sprint. Many weeks will now lie ahead of you where you have to deal with a lot of stress and strain. This is from the clozapine publication that the TRIP guideline group put out. But let's now go to the next slide and briefly review some very initial findings. So as Marco said, we want you to send around the link. People can take the survey. And here in Europe, just an example, next slide. You see that although there were almost 44,000 responses in Europe, 27,000 were fully complete. So there are always some incomplete responses. We'll draw out the data if they include some of the mental health outcomes and people only have 1 or 2 questions missing. So even though it looks like 20,000 are garbage, that's not the case, because many people maybe just skipped 1 or 2 questions or the end. But obviously it's important that people who start the survey have about 30 to 40 minutes available to them to finish it. What's interesting is to see, again, very few kids. So we need to also increase the direct rating of children and adolescents. Now, parents do rate their own kids, which is also important and good. When you look at how people got to the survey, 1/5 via snowballing, family, friends, and colleagues, but almost 40% over social media. And that's consistent across many, many countries. And then mass media, TV, newspaper, if you do interviews, give interviews, if people write about the pandemic and also the COVID study, that's where people then get the link and start answering. You see the age distribution, and you see also that across the board, 2/3 to 3/4 of the respondents are females. Males do not seem to go online to answer the questionnaires. So we'll have to have, obviously, the representative samples in order to balance our results. As you can see, when parents then answer about their kids, there is because that's a distribution of 50-50, their male-female distribution is equal. But the adults, we need more males to respond. Next slide. So what you also see is that we have a pretty high proportion of healthcare professionals. It's about 17% here. In other countries, it's between 15 and 20%. And that is because we obviously send this around among our colleagues. But this is also what we want. We want healthcare professionals that are impacted by COVID-19 and the related work. You also see that in Europe, it's 1/3 doctors, 1 out of 7 nurses, very few psychologists, only 11%. In other cultures, it's almost 40% psychologists, including in South America. So we also need more doctors to respond and nurses. In terms of prior mental illness, we have a maybe more super healthier sample because of the high education level and also sending it out around, amongst colleagues. But still about 17-18% in Europe have a mental illness. The adults versus 51% have physical illness. And then obviously that shifts a little bit in the kids. Next slide. So let's maybe, in the interest of time, because we have a hard stop, let's keep going to South America. Yeah, so here, although this is still a relatively low number of about 3,000 people, mostly from Uruguay, because we had one collaborator who's been very, very active with us, actually doing the red cap entry, Andres, and therefore he got in just the small country of Uruguay, almost over 1,700 people. But I think you can do very well in Brazil too, having all the numbers. But what you see here in South America, it's about almost 40% family and friends. That's due to the Uruguay approach, close networks. But 1/3 is again social media. So use social media, which are pretty cheap, in order to disseminate the information. Here again, 80% are females. Next slide. And 17% are healthcare workers. But as I said, psychologists were very overrepresented, very few nurses. So hopefully in Brazil, you can also get nurses and doctors to respond. And about between 1/5 and 1/4 have mental illness and in their own history, and about 60% have physical illness. So it would be helpful to also get approval for children and adolescents to fill out the survey in Brazil, but at the moment you can start going for the adults. Next slide. So we have 2 countries that we took as representative because they're the highest numbers. One is in Italy, where Marco actually was able to get so many people, and it's much more younger people between 20 and 29, which is great, different from other countries. Again, almost 40% family and friends, 40% almost social media, not so much written in the newspaper, or Italians don't read them. Again, 2/3 are female. Next slide. About 15% healthcare workers, 50% doctors, only 10% nurses and psychologists. So we need a little bit more nursing staff there. And you can see that it's a super healthy sample because they're also young. 9% have psychiatric illness as in the history, and half have a physical illness. Next slide. I think we can skip Germany. Let's just go to Brazil so that we have some question time. Yes, so Brazil, obviously, are just starting. A little less than 50% of the surveys are complete, so hopefully that can increase. You can see here that basically, again, 70% females. The age distribution is almost Gaussian, with the exception of a middle group here. But 50% via family and friends, and the third social media. So maybe once you start giving some interviews on the radio, or also people write newspaper articles, then you also get that increased. And as you don't have kids right now approved, hopefully that can be added for the ethics committee as an amendment. Next slide. I think this is my conclusion slide. No, so sorry, we have here again the healthcare workers, 18%, mostly doctors and psychologists. And the mental health history is higher, so we have maybe a better distribution here. A third is what we would expect in such an aged general population, and 60% have medical history. So let's see how this actually evolves over time. Last slide is the conclusion. Sorry, let's skip over Uruguay. We don't have the time. Okay, so COVID-19, as we all know, and you are now in the midst of it, has seriously and abruptly altered our lives, all of our lives. It's not just restricted to a subgroup. Obviously, the ones who have are given, and the ones who don't are taken even more. So the health and social inequalities will even get larger, and our mentally ill patients are among those that will suffer the most. This environmental stressor affords us with an opportunity to bring mental health and resilience to the forefront that is intertwined with physical health, education, and improvement. And obviously, we need to rapidly collect information about vulnerable subgroups, risk and protective factors, functional as well as dysfunctional coping strategies in order to help this and future pandemics. And the COH-FIT study, the largest of its kind worldwide, can make a contribution, and with your help too. Last slide, just again, the website www.cohfit.com. Please participate and share. Everyone counts. Thanks very much for giving us the opportunity to present these data, and hopefully we have a couple of minutes for question and discussion.
Thank you, Marco and Christoph, for taking our time to do this presentation here. And I think we are in a very good moment to really start to raising our numbers here in Brazil. And I think the presentation that you just gave us, it's a great momentum to really start increasing the numbers. And also, as you showed, we have a huge number of, unfortunately, we have a huge number of people with infections and complications related to COVID. But I would like to ask one question: if it's already possible to compare different trends across countries or continents, and specifically if you have a more, what type of pattern are you observing? If overall the burden in mental health is similar across countries, or if it's possible to see a trend or a relationship between income or human development and mental burden.
So basically, you saw the hottest of the press data on utilization. We have not even started to dig into any of these outcomes. We will do that maybe in 4 weeks. We are looking at maybe analyzing some basic data that can be given to the media without being quantitative, so semi-quantitative, so that they get interested, like how many people feel over-informed or under-informed, what's been the increase in media use and things of that nature. We also included a question on how happy people are with their government and their action. But the real deal, this is a very sophisticated analysis where we need to see how many data we can take from incomplete ones, who do we exclude. We'll both first write papers on the global and only separated by continent for very high-ranking journals, and then we'll see whether they want us to do supplemental material and compare on the country level of countries that have at least 1,000 participants with analyzable data, or whether these will be sub-papers where we do comparison across these countries with enough data to do so. But obviously, this is very interesting. but it's also important to see our study is a cross-sectional individual-based study, but it's a longitudinal cohort study basically across the countries and on a societal level, because we have answers at different times of the pandemic and different times of the restriction. And we'll be able to also plot over time. That takes also a lot of computational power. When in relationship to the height of the pandemic and restrictions within a country, did someone fill it up? One, we have it in the survey itself. I mean, are the schools closed? Can you go out? But we'll also be able to look at that on a country level. But Marco, do you want to add something to the data analysis plan?
No, this is basically it. As you said, the most difficult and delicate part will be the weighting, because we will have to weight the non-representative samples based on the quota of gender, age, and other variables such as region of the country, and also job status and education, most likely. And this will be within country, but across countries, we will also have to weight the data from each country based on the number of responses that we will have. Because countries providing just, 40 responses, they will not have the weight of countries providing several thousands of responses. So this is the plan.
Okay, that's great. I think we are open for questions. There is a little bit of lag between the YouTube and our meeting here in Google Meeting, so I would open for internal questions. Don't know if Euripides would like to do one.
Sure. Thanks again, Professor Correll and Professor Some. We appreciate the opportunity to interact with you guys in Germany and Italy, and I hope the lessons that you were able to learn over there, we can also apply here and grow together during this pandemic period. I always wonder the kind of bias we could have in a project like that, compare who responded, not respond, or type of. So the question, what type of bias would you anticipate, and how are you going to control for them in a study like that?
Yeah, I mean, we do expect people have higher education, being more motivated, better off to answer, and be underrepresented in the groups that are the most vulnerable. But that's exactly why we want to get funding, and I've poured money into the study, and Marco too, to already collect representative, at least online samples, and then we'll weight basically the results based on the representative sample, like co-varying for it, so to speak. And since you are now in the midst of it, you are one of the countries to be selected to actually collect the representative sample at the same time as your non-representative sample, so that there's not even a time lag between it, which will make this a very powerful data set. Now, will we get data from people in the favelas? No, of course not, yeah, unless they have an internet access. So it won't be 100% representative, but at least among the people that take the survey or can take the survey, we will be pretty okay.
Perfect. And in terms of learning from this experience and being able to apply, to bring together some interventions for this current pandemic. So you guys will have outcomes in 4 weeks or 2. So we may, in Italy or in Germany, you guys may be almost after the pandemic, right? At least the first wave. Do you guys anticipate any risk factor or protective factors that can we try to think in terms of applying now, in terms of thinking interventions right now? So you know what I mean. Can we do something right now based on preliminary data that you may have?
So, maybe I go first and then Marco can answer. I think, for me, the pandemic is not over. This is now actually, we have summertime, everybody's outside. I expect this to come back in November, December. We'll have a second wave here. So I think you can learn a couple of things based on a governmental level. So Germany did very well because we are very regimented and people adhere to the rules. And also we kept the hospitals half empty. So we were very preemptive. Before things got worse, we put a lot of restrictions into it. But that's very expensive. We can maybe afford it, having the hospitals half empty for 3 months. We didn't have to have them half empty, we now know, but we didn't know that up front. So we were extra cautious, very preemptive, and that works, obviously. That's on a governmental level. On an individual level, it will be interesting to see what comes out of it, which subgroups do better or worse, and how we can apply the learning there. Hopefully we can give very simple messages like that you need to go outside a little bit once a week or once a day, that you should have family time, whatever the outcomes are, where people who have mental illness do better than people who have mental illness and don't do certain things, so that we can say this is data driven and give them like a little bit of a cookbook advice. Not everybody has a balcony or a garden, obviously. So some of the things will be not modifiable, just knowable, but there are some resources people don't use, and I hope we can point them to that. But on the governmental level, the grant that we just submitted for Horizon 2020 is much more ambitious, where COH-FIT is one individual string that goes into decision making, but we also need to look at governmental action, economic downfall, and all the rest of it. So it's a much more complex interaction of things, I think.
Thank you.
Marco?
Yes, one thing but this is based on my clinical experience here rather than the data, because we didn't analyze them yet, is to use telemedicine as much as you can. Maybe it's not the same of seeing patients in person, but contacting them on a regular basis, especially patients with mental illness, and letting them know that you are there, whatever they need, they can call you, and also promote adherence to medications. And in this way, you can kind of anticipate worsening, or you can spot the worsening as soon as it starts, instead of waiting for patients in the emergency department. That's something I would suggest, but that's based on my clinical experience here in Italy, if you can't see patients in person.
And by long-acting medications, for antipsychotics, for example, that you know that they're taking it.
That's the strong.
Okay, thank you for the answers. We have some questions on YouTube. One question that we have, so not necessarily related to this presentation, is how to increase the rate of health professionals to answer the questionnaires if they are already in a completely burnt out by the demanding at the hospital. So how to increase the rates of this specific group of healthcare professionals?
I think you can, what you can do is interact with the head of departments or the head of the hospital, at management level, so that you disseminate the survey to the employees, basically. This is something that could work as a strategy that comes to my mind.
Another thing, we were totally stressed and we added this project to our plate. So we actually made life worse for us. But why? Because we felt we wanted to learn something. We wanted to give something back and not be passive, overrolled by the virus. So maybe you can say, yes, this will take 40 minutes of your time, but A, you're taking control, you're doing something proactively, and B, you're helping all of us to help all of us. So come on, don't just wait for the next infected person to come and take your time and maybe risk your life. Give back to life of others and feel proactive in combating this problem.
Okay, thank you. We have another question here. I think this was already partially answered by Marco. So how were the questions selected in the survey? But then I would like to complement with another question about the neuropsychiatric symptoms of COVID. So not only talking about mental health, but more about these neurological complications that at the beginning there was a discussion if there was a neuro-COVID or not, but now it's clear that at least in some cases we have. So maybe we would like to comment on these issues.
Shall I go first, Christoph? Yeah. First part of the question, as you said, we already partially answered this. We selected we selected first the validated questionnaires to assess the mental health symptoms, and then we extracted those that we deemed, based on our clinical judgment, the most relevant items for each of these, from each of these questionnaires. In order not to, I mean, if it was a choice that we made, of course we lose in validity, but we gain in comprehensiveness of the outcomes that we assess. Because if we had to ask the full questionnaire, people might probably have been put off halfway. So this is one thing. And the second part of the question, yes, we thought about this. I think, Christoph, if I'm not wrong, I think we added this question after some weeks that the survey was out. But yes, we are actually asking anosmia as a symptom, but not other neurological symptoms. Anosmia, we are asking that.
So yeah, for the anosmia or hypoosmia, we wanted to find out how early before the infection would have started that it could become a warning sign. But the phase 2 and wave 2 and wave 3 of the survey will help us, because we'll ask always, have you been infected by COVID? And then if they have new mental illness or cognitive problems or other things, that could then be the neuro COVID that is different from people who didn't have infection but had mental illness before or didn't have mental illness before. So over time, there will be enough of a group. I mean, we haven't analyzed it yet, but it will be interesting, out of those 60,000, how many actually were infected and answered the questionnaire. We know, I mean, we have collected the data, we just don't know it. And if we then see how they, in a wave 2 or wave 3, maybe even more people who had been infected and survived will answer, we can then compare those against those that hadn't been infected.
Thank you. So there is a question of Professor Eli Welkes that he first would like to say hello to salute Professor Correll, with whom he has been participating and doing research. And so he wants to collaborate in the COH-FIT study, and asking how can he collaborate. But I think that's more a question for us than to you guys. You have already established collaborations, and I would say that Professor Eli Welkes is very welcome to join the efforts, and then we can discuss later about his, of course, great contribution to this project.
Yeah, it would be great to have as many good brains and heads in this as possible, and also use maybe some of the dissemination channels that Professor Elkis has on an administrative level.
Okay, so far we don't have any additional questions. I don't know if Professor Rips would like to complement, or maybe Marina.
Marina first, want to say something? If not, while Marina prepared to say something, I want to, in name of our department, I'd like to really thank you for participating of our grand round. I hope this is the first of several new ones that we can do together. We are also trying to monitor the health, mental health of our professionals in our professional workers in our institution. We have 20,000 health workers here. So we will have interesting data to share with you guys, and from a specific city, São Paulo, and I'll be very happy to share that with you guys. We have just finalized an app, and this is something I want to say in Portuguese in a few minutes to our people here. This app helps for health professionals. So once we use a promise scale where they say how they are in terms of anxiety, depression, and insomnia, and based on the score, they receive videos of mental health promotions. So how to deal with anxiety, how to deal with your insomnia, and so forth. And if they are above a sub-threshold that suggests risk, they are oriented to call our hotline. It's a hotline for health professionals. So this is some of the initiatives we're having. We're also putting together a project about manifestation of the COVID-19 central nervous system. When I follow those patients, and some of them will die, we'll do another autopsy study, including specifically hypotheses like anosmia and desiccating the bulb, olfactory bulb, and try to see if there are evidence of the virus in the brain, getting the brain through axonal retrograde transportation through the olfactory nerve. So this is one kind of research we are doing, and we'll be very happy to share with you guys. But also invite you and I'm very happy to see Andrea here collaborating with you guys, and we have all our support to make this the first of several other initiatives. So again, name of our department, thanks a lot for your participation.
Thank you so much. We had a lot of positive reactions on YouTube, and it would be nice, like, to later know how the data showed and like the results of your research. So you're invited to come back and talk to us whenever you can. It was a pleasure to have you here with us. Thank you so much.
And thank you so much for giving us the opportunity. And before you say something in Portuguese, I mean, if you have really 20,000 healthcare workers, if only every fourth one is filling out the survey, this would be enormous. 5,000 just healthcare workers. I mean, that's more than what I have in Germany right now in the whole population. So please go for it, disseminate it across your entire healthcare workers, and make it a very important initiative. They might not fill it out all on day one, but I mean, we're in this for the long haul. And even if people fill it out after 2 or 3 months when things have cooled down, those responses can be compared to responses when things were really very hot. And that will also be very nice publications that on a country level you can then actually add to when we have written the big papers.
Okay, I'll have I'll get the link, and then we can start like putting in our social media and then spreading it with our groups to help to collaborate with you.
So before I say my last message in Portuguese, Professor Somi, can you project the website of you guys, how people can access the link to participate in the research? Can you do a presentation again with that slide that you present, the website and the link, how people can access the research?
I have the website. I can put it on our YouTube
but
page.
Visualizing it, it's www.COH-FIT.com.
Yeah, so it's here. So I'll say in português in a few minutes. Então essa é um estudo colaborativo que acho que vale a pena a gente contribuir. Acho que esse estudo pretende gerar conhecimentos no sentido de identificar fatores de risco e fatores de risco que vão ser importantes para identificar pessoas em risco, desenvolver transtornos mentais no futuro, nas novas ondas e em futuras epidemias. Mas mais do que isso, que eu acho mais importante, é você identificar fatores de risco modificáveis, coisas que nós podemos fazer a partir de intervenções preventivas, ou fatores protetores que nós podemos promover a partir de promoção de saúde, que possam ajudar a diminuir significativamente o sofrimento da população em geral, com o impacto que envolve todos os fatores ligados a essa pandemia de forma geral. Queria também convidar todos vocês a conhecer esse aplicativo que nós lançamos na semana passada, que basta você digitar no seu Android ou no seu Apple Store, com você, com VC, com você. Digitando, você vai ter acesso, então, a um aplicativo que, de acordo com o teu score, vai te indicar vídeos de promoção de saúde, vídeos que ajudam você a reconhecer sintomas e como lidar com eles. Esse aplicativo também tem uma biblioteca que vai procurar outros vídeos de qualquer assunto que você tiver interesse. Então, a gente acredita que ele pode ser útil em escala para qualquer pessoa. Nós fizemos ele pensando no profissional de saúde. No final, essas pessoas, quando estão com score acima, eles são indicados para uma hotline. Mas a gente tem pensado em trabalhar, porque esse aplicativo tem ganhado escala, de forma que você possa, no final, receber outras indicações de procura de ajuda de acordo com a instituição ou local onde você está. Por exemplo, quem é do SUS vai poder chegar no final e encontrar um número do Ministério da Saúde que oferece psicoterapia gratuita para todo profissional ligado ao SUS. Assim, agora, o pessoal de Ribeirão Preto, talvez algum esteja assistindo, eles estão usando o nosso aplicativo lá vai ter uma hotline também, e assim por diante. Então, essa era a notícia que eu tinha que dar agora para vocês. E, speaking English again, so thanks a lot, Professor Correll and Professor Somi. We appreciate a lot your investment, and we hope this is the first of several. Thanks a lot. And congratulations for the initiative and the impact that this initiative will have. So everybody can anticipate that. Congratulations, and also for the charisma, some way like Professor Somi and you, Professor Correll, were able to have so many people involved. And I'm very happy that André Brunoni so you found the best here to help you guys. So congratulations.
Thank you.
Thank you. Thanks a lot.
Well,
Thank you so much.
And stay healthy and safe as much as you can.
Thank you.
We'll be in touch. Thank you. Bye.
Thank you. Bye. And have a nice day, you all. Take care.
You too. Bye-bye.
Bye.
Bye-bye.